Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Stand Medical Notes. Today we will discuss about acute coronary syndromes and coronary ischemia, the ECG of acute coronary syndromes and ischemia. So it's a very important topic in emergency departments and in primary care centers. So we need to identify a patient, elderly aged, coming with chest pain, and you found something in ECG. You need to refer fast, and you need to give first aid. So this is a very important topic for which the ECG is used extensively in order to know whether there is MI going on in the patient, myocardial infarction, ischemia going on in the patient, so that the patient could be referred immediately and his life could be saved. So let's begin with the name of Almighty. So as we know, ECG is the most foremost bedside triage tool for acute coronary syndrome. We know this one, okay. And one point we should remember here is infarction MI can be ST segment elevation MI, or it can be non-ST segment elevation MI or unstable angina. Other things to note are the Q wave and the R wave abnormalities. Along with STEMI and non-STEMI, we will discuss about Q wave and R wave abnormalities also. Okay, so this is a table, easy table to. We will first discuss about this table, then we'll go on to the ECGs and diagrams. So first one is ST segment elevation. So you found ST segment elevation, so that signifies infarction if the troponins are elevated, tropi or TROP-T or CKMB. Okay, so there are two types of ischemia actually. Transmural ischemia. Transmural meaning the whole wall of the heart. If this is the wall, then whole wall of the heart is affected. That is transmural ischemia. In NSTEMI, what happens is, if this is the wall of the heart, whole wall is not affected, but partial endocardial infarction will be there. So epicardium will be saved somewhat. But if you delay this, then it can spread to the epicardium also. So in NSTEMI you will have subendocardial infarction, and STEMI you will have transmural infarction. Okay. So ST segment elevation, transmural ischemia. When you will say ST segment elevation in more than or equal to 2 contagious leads, and that should be equal to more than 1 mm in limb leads and 2 mm in precordial leads. At least 1 mm in limb leads and at least 2 mm. Nothing but at least 1 small square in limb leads and at least 2 small squares in precordial leads. And what do you mean by contagious leads? So contagious leads are nothing but, for example, in inferior infarction, 2, 3 and AVF will become contagious leads. So in these leads, at least 2 of them, either these two or either these two, like this, should have elevation. So in inferior infarction, these will become the contagious leads. And in lateral infarction, 1, AVL, V5, V6, this will become the contagious leads. And anterior infarction, V1, V2, V4, V5 will become the contagious leads. Okay. And right ventricular infarction, V1 and V2 you will see. These two will become the contagious leads. But instead of elevation, you will have depression. Okay. Then you will attach V7, V8 and V9 leads, and then you will confirm the right ventricular infarction. Okay, this is for posterior infarction. Sorry, this is for posterior infarction. And for right ventricular infarction, this is for posterior infarction. For right ventricular infarction, you will attach V4R and V5R, and you will confirm that ST elevation. So this will become the contagious leads. Okay. Okay. So that is contagious. That is the meaning of contagious leads. So at least 2 mm. Sorry, at least 2 mm. 1 mm in limb leads. Limb leads are nothing but 1, 2, 3, AVF, AVL, and AVR. 1 mm in this at least means 1 small square. Okay, and 2 mm in V1 to V6 leads. Okay, these are precordial leads. So how that MI evolves in ST segment elevation MI? Okay, so what will be the acute changes? Acute changes will be hyperacute T waves. So what are these hyperacute T waves? We'll discuss in detail. That topic is coming. Just remember, there will be hyperacute T waves. T waves will be taller and border and not pointed, 3 points. they'll be taller, and base will be broad. Base will be broad. 1, 2, 3, and apex will not be pointed. Apex not pointed. So that is hyperacute T waves. So that is the earliest sign of infarction. So that can be ST segment, and that will be associated with, after that hyperacute T waves, then there will be ST elevation, either horizontal or convex or party wave. It can be either like this or it can be either like this. Remember benign from malignant ST elevation. You remember this sign, no? So if the ST segment is elevated concavely like this, so if you draw like this, so this is smile sign, no? So that means it is good, not good meaning it is not malignant. So if it is like this, something like this, now if you draw, so it is frown sign. It is frown sign. That means something is not good. Okay, frown sign. So if the ST segment elevation is like this, or if it is like this also, then it is something not good. This is a small thing which you can remember, the ST segment elevation. So first of all, you will see hyperacute T waves, then there will be ST segment elevation, then this is the acute changes, hyperacute T waves with ST elevation, then evolution. Now the ST segment resolves and there will be symmetrical T wave inversion. Symmetrical means both the limbs of the T wave will be symmetrical, that is symmetrical T wave inversion. Then there will be development of pathological Q waves. So Q waves, the deeper the Q waves, the more is the necrosis. More is the necrosis. The deeper the Q waves, more is the necrosis. Q wave implies necrosed tissue. So you can't reverse that. Okay. So ST segment, now it will resolve and there will be symmetrical T wave inversion. Then that is followed by pathological Q waves. So these changes imply necrosis. So when the ST segment is resolving and then symmetrical T wave inversion, then pathological Q waves. These pathological Q waves involve means necrosis. Q waves means necrosis. Not all Q waves, but pathological. What is pathological Q waves? Remember, Q waves whose depth is more than 25% of the R wave amplitude. Okay, R wave amplitude, and whose width is, this is depth, and whose width is more than 1 small square. So this is known as pathological Q wave. The depth should be more than 25% of the R wave amplitude, and the width should be more than at least 1 small square wide, more than 1 small square. Okay, that is pathological Q wave, and pathological Q wave imply necrosis. They imply necrosis. Now you also know that was the changes in STEMI changes, acute changes. Again and again I am repeating so that it should be remembered. Hyperacute T waves with ST elevation, then evolution will be ST elevation resolve, then T wave inversion symmetrical, then Q waves. Localization, inferior leads to be 2-3 AF, anterior lateral will be V1 to V6, 1 in the AL. Posterior infarction is ST segment depression with dominant R wave in V1 to V3, and right ventricular MI is ST segment elevation. See, in normal precordial it is at least 2 mm, no? But in case of right ventricular MI, you can see here ST segment elevation is at least 0.5, means at least half small square in V3R and V4R. V3R and V4R. I said V4R, sorry. That is V3R and V4R. And that should be more than 0.5 mm, meaning half small square, more than half small square in right ventricular MI. Okay. That's all about STEMI. Coming to NSTEMI or unstable angina. So in NSTEMI means the ST segment is not elevated. So it can be either normal or it can be depressed, or no depression, no normal ST segment, but it can be associated with T wave inversion. That is NSTEMI. So ST segment depression will be there. Either the ST segment will be horizontal or it will be down sloping ST segment, and that should be more than 1 mm at least after the J point. So it will be like this, down sloping like this. So from the J point you should see it will be down sloping like this. So if you calculate this amplitude, it should be at least 1 mm ST segment depression. It can be down sloping also, or it can be horizontal also. So I said in ST there are 3 types of ST segment depression: downsloping, horizontal, and upsloping. Upsloping is benign, which is commonly which is seen in tachycardia, but the downsloping and the horizontal is not benign. It indicates ischemia. Okay, and if nothing is there, just you have T wave inversions. Okay, deep symmetrical T wave inversion in V2 and V3, also known as Valence sign, indicate proximal left anterior descending artery stenosis. Deep T wave symmetrical inversion. So this is, so the limbs are symmetrical. Okay, in V2 and V3. So this is known as Valence sign. Remember, this is known as Valence sign, and this indicates left anterior descending artery stenosis, proximal stenosis. Okay. So NSTEMI or unstable angina means ST segment depression that should be at least 1 mm. Okay, and T wave inversion in V2 and V3. Now we will come on to the this Q and R wave abnormalities. So pathological Qs, as I have discussed, that indicates necrosis. Okay, that should be at least more than 30 milliseconds. Just remember, more than one small square. Okay, actually one small square is equivalent to 40 milliseconds, but for the sake of argument, you remember, just for the sake of remembrance, you just remember this one as one small square in width. Okay, and more than 25% of R wave amplitude into adjacent leads. Remember this point, into adjacent leads. This is not contagious leads, into adjacent leads. If this is there, then that those are known as pathological Q waves. Then one more thing is there, something called as poor R wave progression. What is that poor R wave progression? R wave amplitude in V3 should be equal to or less than 3 mm. R wave amplitude in V3 is equal to or less than 3 mm, nothing but less than 3 small squares. Okay, so in lead V3, the R wave amplitude should be less than or equal to 3 mm. What are the causes for that? So the causes can be old anteroseptal myocardial infarction. The cause can be left ventricular hypertrophy. Okay, or the cause can be lead misplacement. So three causes. One is old anteroseptal MI. You ask the patient whether he had MI before. Second, it can be due to left ventricular hypertrophy. Third, it can be due to lead misplacement. If there is lead misplacement, you can know, as you know, AVR is negative always, like this. This will become positive when there is lead misplacement. So you can confirm by this AVR. So poor R wave progression means you should see R wave amplitude in lead V3 that should be less than or equal to 3 mm in lead V3. What that signifies? Old anteroseptal MI or left ventricular hypertrophy, or it can be due to lead misplacement. So that was theory which we should remember. Now we will come on to the charts. Okay, so you can see here, I will zoom it in. Sorry, zoom it in. Okay. Acute ischemia causes a current of injury. That ischemia causes a current of injury. That's why we see ST segment or T wave changes or Q wave changes in the ECG. So with predominant subendocardial ischemia, for example in NSTEMI, the resultant ST vector will be directed toward the inner layer of the affected ventricle and the ventricular cavity. See, the affected vector is directed towards the inner layer of the wall or towards the ventricular cavity, which will be opposite from the leads. The current is moving away from the leads. That's why there is overlying leads, therefore will record ST segment depression. That's the cause. That is the concept behind NSTEMI. Okay, and with ischemia involving the outer layer, transmural or epicardial injury, the ST vector will be directed outward. So the current of injury will be outward like this. So they are towards the leads. That's why the ST segment will be positive here. Here it will be negative because the current is away from the injury, and here the current is outside the what do you call outer. The vector is directed towards the leads. That's why it is positive. So that's the reason. Okay, for depression and elevation in NSTEMI and STEMI respectively. Now we'll see the evolution of STEMI by this diagram. See, before infarction there will be a normal P wave, Q, R, S complex, and there will be T wave. So first change which is going to happen is the hyperacute T waves here, as you can see. Then there will be ST segment elevation. So first hyperacute T waves, then ST segment elevation, and that is going to happen in minutes to hours. Remember this point, minutes to hours. So if you are seeing a patient which is coming and he is having just ST segment elevation and hyperacute T waves, then you should think the injuries, the infarction is happen from minutes to hours. Now, when there is T wave inversion and the along with that there is development of Q wave. Now when there is T wave inversion and there is development of Q wave, then the duration will be from hours to 1 day. Then what will happen? This is not the difference I said in the box. First there will be hyperacute T waves in the end ST segment elevation, then the T wave will symmetrically they'll be inverted and ST segment will start to resolve. Similarly, the Q waves are starting to appear. They are not still pathological. They are starting to appear. Okay. So if the T wave is inverted and ST segment is getting corrected, then that means the injuries infarction is from what is the evolution? What is the time? It is from hours to 1 day. It means it is in hours. Okay. Now there is a development of Q wave. Now see, there is a development of pathological Q wave now. So that means the time from infarction is 1 week now. And now the ST segment is normal and T wave is become also normal. Just there will be Q wave, that is in months. It is in months. So easy to remember. So first you will have hyperacute T waves, then ST segment elevation, that is in minutes to hours, and then you will have T wave inversion. T wave inversion and still pathological Q waves are there, but still they will not be pathological. Okay. Then that is hours to 1 day. Now T wave is inverted symmetrically, ST segment is coming down and the pathological Q waves have appeared, then that is up to 1 week. Okay. So when these two are coming down, that is 1 week. Now ST segment is normal and T wave is also normal, but Q waves will be persisting, that is 1 month. Okay, that's about evolution of MI. One important point is to know about different type of T waves. This is very important. So this is a normal T wave. Sorry, this is a normal T wave. Smooth transition from ST segment to T wave. T wave is slightly asymmetric with a steeper downslope. See, it's asymmetric, no? This limb is, compare this limb to this limb. So though both are asymmetrical. So this is the normal thing which will be there. Okay. This is a normal variant. One more normal is there, but it's a variant of normal thing. So large asymmetric T wave with broad base. Here the base is broad, but still they are asymmetric. The limbs are asymmetric, often in conjunction with slight J point elevation in leads V2 to V4. So slight J point elevation will be there, but patient will not have any chest pain symptoms. Okay. This is actually, it is seen in early repolarization pattern. You see this pattern is known as early repolarization pattern. Okay. So this is also a normal variant. So many patients come to me with this variant and they say, oh, that doctor had done the ECG and there was some elevation like thing and there are T waves. So the doctor said to go to Jayadeva, instead to the cardiac hospital. When I see it was just early repolarization pattern and the patient is young and he doesn't have any hypertension, no diabetes mellitus, no smoking history, and no chest pain history. Just he will have this early repolarization pattern. I say this nothing is a normal pattern. So early repolarization pattern is very much common in young individuals. Remember this point. So in V2 to V4, you will get that early repolarization pattern commonly. V2 to V4, V2, V3, V4. So this is a normal variant. This is early repolarization pattern. Okay, and this is the normal thing. Now large T waves. Now you know that large T waves you see both in ischemia, okay, as well as hyperkalemia. But how you will differentiate those two? Whether this that is hyperkalemia or whether that is ischemic T wave. So that is the difference here. It is shown. Large, remember this, large, symmetric, pointed, short base. Large, symmetric, pointed, short base. It should be large, limbs should be symmetric, apex should be pointed, base should be short. So that is a T wave of hyperkalemia. Okay, these four things. Now, contrast to that, you see here, we'll just take this here. Okay, you just see here in hyperacute T wave, which is a characteristic feature of STEMI. Okay, in transmural ischemia, you will see high, not large, high, broad-based, symmetric, not pointed. So this is the difference. So it is two important differences are it is broad-based and not pointed. Broad-based and not pointed. Broad-based and not pointed. It is broad-based and the apex is not pointed. Apex is not pointed. Broad-based. Here it is short-based and pointed. So that's how you differentiate between the and associated ST segment elevation will also will be there. Okay, almost always seen in conjunction with ST segment elevation. Here you will not have any ST segment elevation in hyperkalemia. That's how you differentiate the waves between hyperkalemia and hyperacute T wave. Okay, large T waves you see in hyperkalemia as well as in hyperacute MI. How you differentiate? 4 points you should remember. And normal wave and normal variant also you should remember, otherwise simply you will make the patient panic that he is having some heart problem. Okay, and this also you should remember, sometimes you will get biphasic T waves, sometimes like this. So positive part and negative part, positive part and negative part, both these T waves are negative, inverted, since the terminal portions are negative. So whenever you get a biphasic T wave, how will you say whether it is T wave positive or negative T wave? By seeing the terminal portion of the T wave, you decide whether it is negative or positive. If the terminal portion is positive, then the T wave is said to be positive. If the terminal portion is negative, then the T wave is said to be negative. Here, as you can see, the terminal portion of the T waves, both are biphasic, but the terminal portions are negative. That's why both the T waves are negative here. One more example here. See here. This is also biphasic, but the terminal portion is positive here. That's why it is a positive T wave. The T wave is positive by definition since the terminal portion is positive. So whenever you get, when you see a biphasic T wave, you should see the terminal portion of the T wave. That will decide whether the T wave is positive or negative. Whenever spotting a biphasic T wave, try to determine whether it is actually a positive or negative inverted T wave by viewing the terminal portion of the T wave. Okay. That is one type. Second, one thing you should remember in biphasic T wave. So three things here: normal variant, second tall T waves, differentiate between hyperkalemia and hyperacute MI, then biphasic T wave. Then coming to inverted T waves. So what are the possibilities in inverted T waves? 1, 2, 3, 4, 5 possibilities you will see in inverted T waves. So step by step, one by one, you will see. See here. So it is symmetric because both the limbs are symmetric, and it is inverted T wave. Okay. So it is post-ischemic, symmetric T wave with varying depth, symmetric T wave with varying depth. So some T waves are having some depth and means they are deeper, and some are not deeper. So varying depth symmetric T wave implies post-ischemic T waves. Ranges from flat T wave, see here the T waves are flat, to very deep T wave inversion. Inverted T waves do not equate acute ongoing ischemia, but rather appear after an episode of ischemia. Remember this point. Inverted T waves do not equate to ongoing ischemia, but rather appear after an episode of ischemia. Okay, that is post-ischemic T wave. How they will be? Their characteristic feature will be these 2 points: symmetric T wave inversions with varying depth, symmetric inverted T waves with varying depth from flat to inverted. Now, ongoing ischemia, how T waves will be there? So here you will be there. T wave inversion with simultaneous ST segment deviation, most commonly ST segment depression. So it will be acute ongoing ischemia. Okay, note that it is the ST segment deviation that represents the acute ischemia. So just having an inverted T wave doesn't make the diagnosis that the patient is having ongoing ischemia. Along with inverted symmetrical inverted T waves, you should have a deviation of ST segment, either elevation or depression. Most commonly it will be depression. So T wave inversion with simultaneous ST segment deviation implies ongoing ischemia. So that is how you should differentiate from post ischemic or ongoing ischemia. This point is important. T wave inversion along with ongoing ST segment deviation implies ongoing ischemia. And symmetric T wave inversion, but there is no ST segment deviation, that means it is post ischemic most likely. One more important point you should remember here, there is something called as cerebral T waves. Cerebral T waves. So whenever there is cerebrovascular insult, for example, a stroke or hemorrhage, okay, hemorrhagic stroke or ischemic stroke, you will have T waves in the ECG. So very deep, gigantic T wave inversions in the chest leads. Chest leads meaning V1, V2, V3, V4, V5, V6. These are the chest leads. So very deep gigantic T wave inversions in the chest leads. So they are a result of some cerebral event. Okay, some studies report this finding in up to 30% of with intracerebral hemorrhage. So in patients with intracerebral hemorrhage, 30% of the patient can have this T waves in the chest leads, deep gigantic inverted T waves. Okay, deep gigantic inverted T waves, but you will not see any, you will not see again ST segment deviations here also. Remember that point. Now hypertrophic cardiomyopathy is also one more thing which where you can see this one. So symmetric T wave inversions most commonly in V1 to V3, often very deep and accompanied by large R waves. Often very deep and accompanied by large R waves, occasionally accompanied by ST segment depression. Okay, so that is not due to ischemia but due to hypertrophy of the muscle of the heart, hypertrophic cardiomyopathy. It can be dilated cardiomyopathy. Okay, no, not dilated, sorry, it is hypertrophic cardiomyopathy. So how you will differentiate that? The waves will, the inverted T waves will be seen in from V1 to V3, and there will be symmetric T wave inversion most commonly, and they will be often be accompanied by large R waves. Large R waves. Large R waves indicate hypertrophy of the heart. No, so combination of two. One thing, large R waves along with deep symmetric T wave inversion from V1 to V3. So this you see in hypertrophic cardiomyopathy. So when you compare it with ischemic T waves, there you will have T wave inversion plus ST segment deviation. That is ischemic. T wave inversion plus R wave, large R wave is nothing but hypertrophic cardiomyopathy. T wave inversion, but there is no ST segment deviation, that is post ischemic. Okay, T wave inversion, gigantic inverted T waves in chest leads, that is in, so we'll summarize that one. Okay, last one we should see. So this is perimyocarditis, nothing but pericarditis or myocarditis. So whenever there is inflammation of the heart muscle, there will be T wave inversions occur after normalization of the ST segment elevations in perimyocarditis. T wave inversions often seen in most leads. This is important. As you know, when there is pericarditis, there will be ST segment elevation. But to differentiate it from the coronary syndrome or myocardial infarction, how you will differentiate that ST segment? The ST segment elevation in the MI will be restricted to the respective leads like inferior leads or lateral leads or anterolateral leads or posterior leads. But in pericarditis, there will be diffuse ST segment elevation. Diffuse means almost all the leads will have ST segment elevation. So that's how you differentiate between coronary syndrome and pericarditis ST segment elevation. And along with that, you will have PR depression in these patients. And one more thing to differentiate is the ST segment elevation in pericarditis will be concave, not convex or flat, like in acute coronary syndrome. So you will have this one, but when the pericarditis will resolve, you will have T wave inversion. So remember this point. Whenever the pericarditis resolves, also, so you will have post pericarditis T wave inversions also. So 5 things we have learned in this T wave topic, negative inverted T wave topic. So just I will summarize. So one is post ischemic. I will write here. Sorry. So one is post ischemic. Why should I write here? Here only will do this. One is post ischemic. So what is the characteristic? It will just symmetric inversion, symmetric T wave inversion, and there will be no ST segment deviation. So that is post ischemic. That is the characteristic feature of post ischemic. And ongoing ischemia, you will have symmetric T wave inversion This is one. First point. Second, it is associated with ST segment deviation. So that is ongoing ischemia. Okay. Then third one, cerebral T waves. In 30% of the patient, just you will have T wave inversion. That's all. And T wave inversion, 1 point. Number 1 point, you will have T wave inversion, where you will see that T wave inversion in chest leads in 30% of the patients, cerebral T waves. Okay. So these two are important actually. This is not common and this is not important also. Okay. This is important, post ischemic or ischemic. Okay. And due to this, now in this one, hypertrophic cardiomyopathy, you will have symmetric T wave inversion from V1 to V3, from V1 to V3 along with large R waves, large R waves. So this plus this means there will be hypertrophic cardiomyopathy. So remember, you will have not have any chest pain here, you will not have any chest pain here, you will not have a chest pain here. Chest pain will be present in here, this induced here, this point and this point. You will have chest pain. Okay. And in this one, last one, this is after the attack of perimyocarditis. Here you will have T wave inversion that will be diffuse. Second point is diffuse T wave inversion. Diffuse. Okay, so these are the 5 kind of things which we can have in T wave inversion. We should remember, and to make it easy, whenever there is T wave inversion, just exclude MI. Just think it as ischemic. And if the patient has symptoms, T wave inversions are there, and if the patient has symptoms, just think it as MI and just send the troponins to confirm that. It is easy. Okay, but along with that, you should remember these things also. To make it easy, just you send for troponins if the patient has symptoms. One is post-ischemic. I am revising this one. Post-ischemic. Second is ongoing ischemia. Third is pericarditis. Common things we'll put first. Okay. Pericarditis. Fourth is hypertrophic cardiomyopathy, HCOM. Fifth is cerebral T waves. Okay. Something related to the CNS. So these are ischemic, pericarditis, hypertrophic cardiomyopathy. So basically 3 things are related to heart, different things. And this is the most important among all these 3 things. And one thing is related to the brain. That's how we can remember. Okay. I think it is enough for today. I think it is enough for today. We have covered half. I think it is not half also. The initial part, 1/3 part of acute coronary syndrome. Next things we'll discuss in the coming video. Thank you.